Executive Officer of the Ph.D. program in Economics at the Graduate Center. It's a pleasure to welcome you to this year's Alumni Day celebrations. We have an exciting program with award distributions and roundtable discussion on the Affordable Care Act. As you know, the Graduate Center is a doctoral granting institution of the City University New York system. It was established in 1961 to provide graduate education to CUNY students. But what few know or remember is that the economics program, one of the 4 founding departments of the Graduate Center. It started to award these degrees as early as 1967, and since then has generated an impressive roster of distinguished alumni, more than 350, almost 400 by now, in academia, government, business, and the financial sector, spanning several countries, of course, including the United States. Each one of our academic years is brimming with activities, colloquia, and seminars, and where our students get a top-notch training in economics. Our annual newsletter describes all these activities. I presume that you are all getting this, and if you are not getting, please make sure that we have the correct email address for you. And this newsletter was a special one, as we were delighted to announce Paul Krugman's joining the program in fall 2015. Among these activities, the Alumni Day, a tradition that we started back in 2009, has now become a well-established feature of our year-long activities, with roundtable discussions on various topics of relevance. This year's generous contributions and gifts of our alumni helped us to introduce for the first time an alumni award ceremony, which I'm delighted to announce. But before I go further, I'd like to express my gratitude to our sponsors, the Doctoral Student Council and the Advanced Research Collaborative Center, ARC, and to Diana Santiago, our Assistant Program Officer, who worked tirelessly to help organize this event. Thank you, Diana. And all the students who contributed their time and energy, especially Drew Green and Ian Haberman, who's in a course, in micro. Yes. This is a truly unique and amazing department where everyone is always ready to lend a hand. A first of these awards is a very generous grant that is offered by the CIT Bank in partnership with Ray Quinlan, an economics program alumnus, and a great friend of the program. Ray got his PhD in 2007 and wrote his dissertation with Professor Thurston on household consumption behavior using micro data. Until recently, he was the executive vice president at CIT. Then in February, he took a position of CEO at Sallie Mae Bank. Ray serves also on the board of trustees of the Graduate Center Foundation, as well as on the recently established advisory board of economics program. He unfortunately is out of town, and he regrets not being able to present himself the award since he's not here. But he asked his colleague Jennifer Armstrong to present him at the back, and Jennifer graciously accepted. So Jennifer is here, is the Senior Vice President of New Product Development and Chief Marketing Officer in the Banking Division of CIT, where she served with Ray in the establishment of Internet Bank. Now she will present the CIT awards to students. Thank you.
I only speak one other language, and it's Italian, and nobody here seems to be Italian, so, okay. All right, you 10. CIT Bank, and just to give you a little bit of background, Ray, Quinlan, and I have worked together for probably over 25 years. Most of our careers have been at Citibank. And after the financial crisis, and we were asked to go to CIT because, as many of you might know, CIT had taken $2 billion of TARP and went bankrupt for 45 days. They're the fastest bankruptcy I think I've ever read about. When they came back with a clean balance sheet, they were then under regulatory regulation and became a bank holding company. So Ray and I went to CIT and really had to build a bank from scratch in about 8 months. And we did build an internet bank for CIT. So he was the executive vice president of banking. That put them under regulatory control, but brought in a lot of deposits for them so that they could then obviously go to FLUB, or the Federal Home Loan Board, and borrow against the Federal Home Loan Board. And John Thain was the CEO, so we could bring down most of the expensive funding. So we were brought in for low-cost funding. Ray and I did that for 3 years. I'm still at CIT. He did leave and go to Sally Mae. What am I going to do with him, right? And then he calls me up and says, I can't make it. Can you do this for me? So I said, it would be my pleasure. But on behalf of CIT, the bank is happy to give the grant for economics. It's one of the things that as an institution, we focus on education, and we focus on low to moderate income housing, so that we think that people who live in better places, the people who are more educated and can get education and help themselves as well as their communities and countries, then that's what we want to focus on for the future. So it's our honor to give this grant to the school and to the students that receive them today, and thank you for having me and Ray participate. Thank you.
Three more awards, and thanks to your contributions since his untimely passing away, we established the Salih Nefci Memorial Award to remember Professor Nefci, not only for his achievements, but also for the remarkable person he was, and to keep his memory alive with us. The Salih Nefci Award in Macroeconomics and Finance for the best paper in the field goes to Hiroshi Morita. The second of these grants is the Nadia Deutsch Award for the best paper in international macroeconomics. Nadia, who also regrets not being out of town, as was really decided at the time to do this, is an alumna who graduated in 2007 and wrote her dissertation on FDI and growth under my supervision. She's currently an associate professor at Brooklyn College. This award goes to Leon Sorkin for his paper, The Law of One Price and the Financial Crisis, Evidence from the US and the Canadian Equity Markets. And the last award is the New York Women Economists Award for a female economist working on an applied microeconomic paper. This award goes to Luz Salas for her paper, Private versus Public Mental Accounts, Experimental Evidence from Savings Groups in Colombia. This is one of the many awards, international awards, and very prestigious international awards that Luz got. And
Thank you very much. Thank you.
And she came with her in warm way. grateful for our alumni for providing such prizes to our students and for their continued support and engagement with the program. I'd like to emphasize that private giving by alumni and friends really makes a difference, makes a huge difference. We couldn't make these awards without your gifts, and there are many additional activities that we could give your gifts to raise the profile of our program. So you may think that, oh well, my little contribution won't make a difference, but it really does. So we are who we are, not only because of our distinguished faculty and hardworking and successful students, but also because of our alumni, of whom we are so proud. Thank you for all. So next, and now we're moving to another exciting part of our program, which is going to be the roundtable discussion, and I will invite our panelists and introduce them. Can we start? Okay, so now we can start our roundtable discussion. Let me give a little bit of introduction and background to, if you haven't been before for these discussions. We have been organizing these discussions during the Alumni Day since 2010, and they have been, these discussions have gathered accomplished experts and cover a wide range of timely issues designed to highlight issues of relevance to each of us as individuals and to our society. 4 years ago, the first of these conversations was on government debt at the federal, regional, and international levels. The next one discussed the future of quantitative finance, and that was just after the financial meltdown. And last year's examined unemployment at again, regional, national, and international levels, at a time when unemployment reached historic highs. Today's topic is yet another important policy issue, the Affordable Care Act, in other words, Obamacare. This event is organized together with the Doctor of Public Health program, and the discussion, as you know, is entitled Affordable Care Act and its critiques, the good, the bad, and the ugly. We're fortunate to have with us accomplished scholars and a moderator who are all experts in this subject. They will be in conversation with our moderator and with each other. So I'm delighted to introduce first Shoshana Solver. She's sitting at first. Doctor of Public Health, Robert Luciano, Professor of Healthcare Policy at the School of Public Affairs at Baruch College and the Graduate Center. Professor Solver received recently the prestigious designation as Loren and Brock Lubin Distinguished Visiting Professor at Weill Cornell Graduate School of Medical Sciences. Before joining CUNY, she held positions at School of Public Health at UCLA and George Washington University. Dr. Solver has participated actively in efforts to expand insurance coverage. She served as a working group chair on the Clinton White House Task Force on Healthcare Reform and as a member of the Institute of Medicine Study Committee on the Consequences of Uninsurance, leading their efforts to articulate principles and recommendations for achieving universal coverage. A member of Academy Health's Board of Directors and Methods of Counsel, Dr. Solver has widely published in many areas of healthcare policy and is recognized as an expert on the use of qualitative and mixed methods in health research. It is also my pleasure to welcome Dalia Remner. She is the third one, professor at the School of Public Affairs, Baruch College, and the Art Program in Economics, the Graduate Center, and a research associate at the National Bureau of Economic Research. She received her Ph.D. in economics from Harvard University. She's been a Marshall Scholar, a dissertation fellow at the Brookings Institution, an agency of healthcare research postdoctoral fellow at Harvard Medical School. Professor Remner was on the faculty of Tulane and Columbia School of Public Health. She also has published widely in a variety of areas in healthcare policy. Professor Remner focuses on incorporating health insurance as a necessity into poverty measurement, higher education policy, teaching and learning, and journalism. And she also blogs and reads. And it is my particular pleasure to welcome Alumni, a distinguished alumnus of our program.
You can figure out the line.
Right, I don't need to specify. He's a professor of health economics and associate dean for academic and faculty affairs at the Rutgers University School of Public Health. A research associate at the National Bureau of Economic Research and an elected member of the National Academy of Social Insurance, a fellow of the Employee Benefit Research Institute. Alan is also a research professor at the Rutgers Institute for Healthcare Policy and Aging Research and its Center for State Health Policy. He's an editor and co-editor in journals and published work that appeared in a number of professional journals. He has held research positions at Boston University and the Agency for Healthcare Research and Quality. He was a member of President Clinton's Health Reform Task Force, received the Administrator's Award for Health Services Research, and was appointed to the DHS as Senior Biomedical Research Service. Finally, I'm delighted to introduce our moderator, Tammy Lubin, a senior writer at CNN Money. Tammy covers the Affordable Care Act, income inequality, middle-class issues, and the government safety net. Tammy is also a seasoned journalist. Previously, she covered personal finance in Newsday and worked at Crane's New York Business and American Lacquer, as a Metro reporter at the Home News Tribune and the Aspen Park Press in New Jersey. And she also teaches journalism at the Columbia Graduate School of Journalism. Please join me in welcoming our distinguished guests.
Welcome, everybody. Just a little bit more about my background. I started covering Obamacare a year ago. We didn't at CNN Money have anyone assigned to cover Obamacare, but I was covering the safety net, so that included Medicaid, unemployment benefits. And at that time, there weren't that many articles, there weren't that many journalists really writing a lot about how Obamacare, the Affordable Care Act, were going to affect people, or the articles weren't getting through to the public because the articles that I was writing, I would send out tweets, or we would ask questions and ask for reader comment. And most people said, I don't understand this, I don't know what it's going to mean for me. Unfortunately, many Americans still feel that way now after open enrollment is closed. But I saw how important it was as a journalist whose goal is to communicate information and educate people, how important it was to really break this down for people and to explain to them what it means for them, what it means for the country in general, what it means for insurers, what it means for hospitals. It's really quite a wide-ranging, an important law that's going to affect a lot of people. So I've been covering it for a year, and of course in October, everyone, especially with the wonderful meltdown of healthcare.gov, it became, front page news. So now I think there's a bit of a lull with the open enrollment period closing, but there's going to still be a lot of important stories coming out, and a lot of important coverage on how it's affecting healthcare and how the people who've gotten insurance, maybe for the first time in years, for the first time in their life, are actually using health insurance. So I just wanted to start before I get into a brief overview of ACA. I'm curious who is in the audience. Do we have mostly economists here? Are there people from the School of Public Health? Two? General public? Okay, very good. Anyone else? Insurance broker, okay, that's good. And a local scientist. Okay,
Political.
And how many people would say they're very familiar or know a lot about ACA? People are here to learn more? Okay, wonderful. Well, that's great. So just a brief overview. Hopefully some of you guys already know this information, but just to put us all on the same page. The Affordable Care Act was passed 4 years ago, mainly with the goal of reducing the number of uninsured and also to some extent controlling healthcare costs. It's touched many parts of healthcare and it's generated an enormous amount of controversy, as we all know. Insurers, for instance, now have to put 80 to 85% of their premiums towards medical care or quality improvement. In the first 2 years, insurers paid consumers more than $1.6 billion in rebates in order to meet this provision. Hospitals now have to pay a penalty if they have excessive Medicare readmissions. Community health centers have become, more prominent. They're receiving $11 billion over 5 years for operation, expansion, and construction. The law provides millions of dollars to increase the number of primary care providers. It's looking to train doctors, nurse practitioners, and physician assistants. And healthcare spending has slowed to record lows in recent years. Some people will say that's thanks in part to Obamacare. Talia will not. She can argue about that on the panel. That's fine. There have also been obviously plenty of criticisms. People are accusing the government of requiring, being too intrusive, requiring people to get coverage. Employers are cutting jobs because of this. People are losing their doctors. You'll hear stories of patients dying because they've lost their insurance that they've had for many years, which is the only insurance that will cover their cancer treatments, etc. And then, of course, the most important for right now is the mandates. Most Americans must obtain coverage, and employers with more than 50 employees must offer affordable coverage, and that's mainly the aspect that our panelists will look at today. So a quick summary on where we stand in the Affordable Care Act. We just finished the open enrollment period on March 31st. The early technical problems on the front end were largely fixed. There's still a lot of back end problems with insurers that have yet to be fixed. The government is not able yet to accept electronically from insurers which of their members are eligible for subsidies, and there have been a lot of problems with Medicaid files being transmitted to the states. But on the front end, from what most Americans see, healthcare.gov is largely working by the end. More than 8 million people have signed up, although we don't know how many people have paid and enrolled yet. They're roughly saying it's about, most insurers I've spoken to and other journalists have spoken to say it's maybe in 85%, in the 80% range. So if it's 85%, it means there's 6.8 million people will be insured. However, unfortunately, we don't know how many people did not have insurance before that, so we don't know how many are newly insured. Of the people who signed up in the exchanges, 85% of them got financial subsidies. More women than men signed up. 54% were women, 46% were men. That's not necessarily a good thing for insurers. Most people who were signing up were also white. 63% were white, 16.7% black. And Latinos, who were a particular target of the Affordable Care Act and a lot of outreach efforts, did not sign up in the numbers people had hoped. They only 10.7% of those signing up were Latino. And then relatedly, half the states in America have expanded Medicaid to adults at 135% of poverty, which means more than 4.8 million people, the government has said that more than 4.8 million people, additional people have enrolled from October to March. Although again, we don't know how many people were benefiting from the expansion versus how many people, the so-called woodwork effect of how many people were already eligible but had not actually signed up, but heard about it through all of the outreach efforts, so then came and signed up. But there's still a big coverage gap that's affecting millions of people, so you have a lot of people in states like Texas and Mississippi and other places that had not expanded coverage, where people at 100% and higher, 100% of poverty and higher, are able to get subsidies, but adults with below 100% of the poverty line are generally not able to get Medicaid in a lot of these states. The qualifications, the income qualifications in many of these states is extremely low. So now you have people who are most in need who are not eligible. But I will let the panelists continue discussing this, look at various aspects of health reform and how it's affecting Americans and healthcare in the U.S. So, Sean, let's start.
Good evening. So because I'm not an economist, they put me up first. So that's so you can savage me and then have be done with savaging and then not savage your economists over here. So I just want to reiterate that the clear and primary goal of the ACA was in fact to increase the number of people with insurance in the United States. And I would actually disagree with the statement that another primary goal of the Affordable Care Act was to control healthcare costs, because I think that if they had really tried to control healthcare costs, it would never have passed. And I think that we are very naive in this country in thinking that somehow magically we can control healthcare costs through almost any mechanism. I've been at the business of health policy now for about 30 years, and I'm not hopeful. And I'm very depressed by the fact that we spend so much money on health care, because I think that we would get better benefits to the health of our population if we spent some of that money on education, on transportation, on housing, on economic development, rather than on health, because those social determinants of health have a huge impact. And one of the impacts that they have is, in fact, on who's insured and not. So it's also important for us to recognize that the reason that this act was passed is not just because a person like me may believe that having as close to universal coverage as possible is a morally right thing to do. It is because there are some real harms that result from the fact that people are uninsured. It is associated very strongly with worse health care, financial insecurity and bankruptcy for people without insurance, and in some cases very ineffective use of the most expensive services, such as emergency rooms, which is again a very difficult, not an easily tractable problem, how to get people to stop using emergency rooms. It's a complex, really a social problem that we haven't fully addressed. Now, Mary mentioned that I was on a wonderful, I enjoyed all 3.5 years of participating in the Institute of Medicine study of the consequences of uninsurance. We put out 6 reports over about 3 years in the early 2000s, and I am going to be showing you a couple of pieces of information from those different reports. First, the health consequences. According to our study, working age Americans without health insurance, and that's what we concentrated on, because older people are basically have coverage through Medicare. They receive too little medical care, and they receive it too late. They are sicker, and they die sooner, and they receive poorer care when they are in the hospital, even for acute situations like a motor vehicle crash, where you wouldn't think that they would be doing what's sometimes called a wallet biopsy as they come into the emergency room. How do they know these people are without insurance coverage, and how can that possibly influence their care? But apparently it does. So one of the clear factors that I'm intrigued that you mentioned that you also cover income inequality, because income inequality is a major factor behind the lack of insurance. And it's very important for us to recognize that just as health care has gotten more and more expensive, naturally, health insurance has gotten more and more expensive and more out of the range of the affordable for more and more Americans, which is one of the reasons why we have largely been depending either on employers or on government. And I'm really curious to see how that's going to change over the next few years. Probably one of the most controversial findings in the IOM study's work was from a study we did called Hidden Costs, Value Lost, in which we estimated that the potential economic value to be gained in better health outcomes from continuous coverage for all Americans was estimated as being between 65 and 130 billion each year. And that was basically 10 years ago that we're talking about. So it'll be double or triple that given the inflation. Because that assumed that the uninsured would use healthcare at about the same rate. It includes, but it is not limited to, higher expected lifetime earnings due to increased productivity and educational and developmental outcomes. So, as I said, this getting people insured is the core. But I have to say, this was not a universal coverage bill. From the outside, it excluded about 10 million or more people who were insured because we did not have the stomach to insure everybody, including people who were immigrants, perhaps without papers. The IOM recommendation was truly universal coverage. People were actually shocked at that we said, well, we're supposed to be evidence-based. So when we were asked, why are you including all this, I read between the lines, rabble here in this country, the answer we came up with, there is nothing in the evidence that shows that there is no good reason to insure these people. So it was, from an evidentiary perspective, they're no different from anybody else. So we have now, we expected that about 35 million people would gain coverage. I think this number is now wrong. I think it's more than 10 million people. And one of the reasons is because often the numbers are only talking about the marketplaces and they're not including Medicaid. And one of the things that I want to also mention to you, in case you happen to know poor people, is that while open enrollment in the marketplaces is closed, enrollment into Medicaid is not. And that goes continuously throughout the entire year, and it's going to be very important. The real sadness for those of us who really care deeply about people being insured is a Supreme Court decision, which, as it was combined with really what I would call a vicious political environment. When we started talking about the good, the bad, and the ugly, that was a suggestion that Alan had made. Part of what we were saying was ugly was a lot of the misinformation about the act, which was not well countered by the administration and its allies in terms of its communication. So we have a lot of people that, as Tammy said, the poorest in a given state like Texas are not going to be covered, the near poor are going to be covered. What I want to really emphasize here, because my concern has always been, how do you reach people who are in these very hard to reach populations? And that's been where the challenge is. We have a lot of knowledge about how to do this, and I have to say that sadly, the administration didn't really take full advantage of it, particularly at the federal level. Some states did an excellent job. I spent 20 years in California where they're good at this, and where they put somebody in charge of the marketplace who really knew what he was doing, and they didn't have any problems with their website, and they enrolled an awful lot of people. Yeah, they did. They enrolled a lot of people. They had some, but I don't think they were like anything like, nothing like what we were talking about here. But I think that the basic issue here is that one of the failings, I believe, of the Obama administration and their allies with respect to this is that they did not do an adequate job of communicating to the American public. And I think, Tammy, that you're right, that it still isn't happening, that it still isn't clear to people, because it hasn't been broken down into language that people can understand. So I'm going to really actually move to my last slide, which are my take-home messages for you folks. The ACA was intended to substantially reduce the number of insured people, but not to zero. The uninsured pay high costs in healthcare and in productivity, and we as a society pay and lose the value of their potential productivity. The Supreme Court decision means that many really poor people will remain uninsured, while people with more income get insured. I'm really stunned, actually, by that figure of 85% of the people in the marketplaces getting some level of subsidy. That's pretty amazing. And we have to do a much better job at enrolling those who are eligible, not just to create a healthy risk pool, which was the emphasis right up front, right? Get the young and healthy people in there, but because we want to be able to serve those who are in greatest need. Thanks very much.
So I want to talk about what the Affordable Care Act does and does not solve. So a lot of the attention you've seen, the news and so on, is focused on the website problems and on the exchanges and a lot of those things. But in the most fundamental sense of how the Affordable Care Act is needed, those aren't what really important. There are really two things that are essential. The insurance market regulations that mean that people can have health insurance through life, no matter how sick they get, and the subsidies and the expanded Medicaid where we get it, which means that people can afford health insurance. So each of those changes are designed to fix one big problem each, and I want to talk about them because as people fight about this and fight about how we should change it and try and give it more public legitimacy, I think it's really important that these things are understood. So why what's the key market failure with private insurance? It's not what people tend, with health insurance, it's not the ones that, I know we have mostly economists here, that economists tend to think of, oh, we have an asymmetric information problem causing adverse selection. Well, we do have an adverse selection issue, but the real problem in health insurance is that I can't protect myself over time. So everyone knows what insurance is. I don't know if something bad is going to happen to me. We all pay premiums to the insurer collects them, they pay out to the person the bad thing happens to. Fine. Fire insurance, fine. For health insurance, if you start healthy. What happens when I'm not healthy? When I know I'm sick, I know I have cancer, my insurance contract has expired, I don't need insurance. No company is going to basically sell me something for $8,000 knowing they have to turn around and pay $100,000 of care out for me. That's not insurance. And in the past, when some nonprofit insurers did that, they can't survive if other insurers don't. They attract the healthy people. So that's the real market failure. And for those of you who are interested, there's a 1995 JPE paper by John Cochran, which is probably one of the most neglected papers in health economics. So that's the problem, and how do we fix it? So in the public domain, what's very popular is, don't allow the insurers to charge more for if people are sick. They just have to charge everything else. They don't know or care about what insurance is supposed to be. Just have community rating in the jargon. Well, the problem with that is the sick people say, great, I'm buying insurance, as we saw in New York and New Jersey. They buy it, healthier people are like, ooh, that's expensive, don't buy it. We have a death spiral in terms of who's insured. And even within the insurance plans, among those are insured, better, richer insurance, the ones that include the cancer cares in their networks, they attract the sick people, the premiums go up, the healthy people go elsewhere, those plans go back. So there's two different types of death spirals. So those are the reasons for the three main insurance regulation pillars of the ACA. The individual mandate, the community rating, and the risk adjustment. Risk adjustment you take from the plans with more than average sick people and you give to the plans with fewer than average sick people. Sorry, thank you very much. That often happens when I teach too. So that I think is probably the most important thing, and that is what I think a lot of the people who are opposed to the government interference kind of need to understand is that there's not really a better way to resolve that market failure other than forcing everyone to move together. Making insurance affordable to all, people do know that even a lot of middle-class people actually can't afford what health insurance really costs for good reasons, for what it does. There are some aspects, which I hope we can talk about later, about why the United States is excessively expensive in ways that it doesn't have to be, but most of the expense is completely legitimate. So what doesn't it solve? As I think Shoshana already mentioned, it doesn't really address our healthcare cost problem. There are some exceptions for what it does. There's accountable care organizations, which are for Medicare, a fancy incentive to have cheaper, better care. There's an obscure thing called the Medicare Productivity Update Factor, which may or may not be having a big effect, and that is from the Affordable Care Act. And there's the idea that the plans will compete and that'll bring down prices and maybe even fines medical care. For the most part, however, it doesn't fix that. And if it were going to, it would need to address either the high prices or the quantity of medical care in both, and that would be micromanagement, and that wouldn't fly, obviously. People would not want that, although we have some of that in Medicare. There's lots of other problems that the Affordable Care Act doesn't address, but it has those important ones. Another one that I think was alluded to was complexity. We have an extremely complicated, quote-unquote, system in the United States. A large part of the complexity of the Affordable Care Act is just because of that. Some things are gratuitous when put down without, but a lot of that's because of that. And this is about 1/6 of the economy almost. It's a matter of life and death. We will not be dismantling that complexity quickly or easily. So, okay.
Thanks. What I'm going to do at the outset is try to convince you that the Affordable Care Act is not a radical approach to delivering medical care. So despite the rhetoric, it's hardly a radical approach. It builds upon many of the regulatory and structural features of our existing healthcare system and health insurance system. For example, it builds on state insurance market reform laws that have been in place for probably 25 or 30 years. It builds on the young adult expansions that were done at the state level. It preserves the private insurance system. There's no single payer, for example, and so on. The other thing to recognize is that the ACA also builds on a number of legislative proposals that have been advanced in the 50 years since the enactment of Medicare and Medicaid. So, for example, if you were to look at something called the Health Equity and Access Reform Today Act, which was proposed in 1993 to counter President Clinton's health reform, you would see that that law contained an individual mandate, fines on employers for not providing coverage, bans on pre-existing conditions, state-based exchanges, and so on. So this is just the ACA can be viewed as a kind of natural evolution. However, the ACA does represent some fundamental changes in the way we think about healthcare. First of all, the ACA validates healthcare as a right, as part of the social contract, but also as an obligation. It's also, the ACA also represents a shift from an emphasis on willingness to pay for health insurance and healthcare to one that focuses on ability to pay. It also integrates social insurance principles into a private insurance market, and there's a real emphasis on consumer protection. Now, as I think both Shoshana and Dahlia may have mentioned, the ACA hasn't emphasized solving the cost problem, but it's emphasized the access or equity problem. And so the key issue that I want to explore here is, does an emphasis on equity necessarily compromise efficiency, or might it actually improve efficiency in healthcare markets? And I want to very quickly talk about the individual mandate, labor market implications, and the issue of moral hazard. Now, with regard to the individual mandate, some view it as a coercive intrusion on consumer choice, but the mandate does address a basic issue of fairness. That is, that individuals should pay for their health care to the extent that they're capable of doing so, and if not, subsidies should be available. Okay, they shouldn't shift the cost to other individuals. So the mandate addresses a basic efficiency issue as well. It avoids a free rider problem and pecuniary externalities. It avoids market failure due to informational asymmetries that lead to adverse selection. And without a mandate and the kind of regulations that are in place with the ACA, for example, adjusted community rating, open enrollment, no pre-existing conditions, basically you could have an adverse selection death spiral, as happened in New Jersey, and I have some slides that I may have an opportunity to show later on. But the key issue with the mandate is whether individuals value the mandate and are willing to pay. If they're not willing to pay, if they don't value it, we have to make them whole, and subsidies are available. The mandate also, I think, addresses this issue that Dahlia raised about community rating, because I think what the mandate does is it kind of imposes a required lifetime insurance contract. You always have to be continuously insured. So, for example, if you're the beneficiary, if you are being taxed when you're young to, in effect, compensate or subsidize people who are older, well, when you get older, young people will be subsidizing you as well. So there's that lifetime issue. The ACA also has some important labor market implications. For example, the fact that you can go to a health insurance exchange addresses issues such as job lock, retirement lock. It also may enhance entrepreneurship as people become self-employed, because now they can get coverage through the exchanges. And it may permit individuals to make better labor market or labor force decisions regarding participation, hours of work, the types of jobs that they take. And also, the young adult expansion of the Affordable Care Act may permit younger individuals to invest in their human capital, go back to school, because they can continue to get coverage through their parents. And there's a paper forthcoming in the Journal of Health Economics that suggests that wages in states that adopted the expansions, wages for young people have actually increased. However, such improved equity via the ACA can also negatively impact efficiency. For example, workers may decide to reduce their hours of work because if they work too much and earn too much money, they will be ineligible for the various premium subsidies and cost-sharing subsidies that are available. So that could unnecessarily cause them to change their labor supply. Employers may, for example, reduce their workforce below 50 full-time equivalent workers to avoid the fines associated with the mandate. Some employers, for example, may also decide to reduce their labor supply in order to qualify for some of the subsidies. Okay, I want to sort of finish up. There are a bunch of other issues that I could discuss, but I don't have the time. But I also want to finish up with the notion of the implication of the ACA on moral hazard, because obviously with a big insurance expansion, the notion is that individuals will overutilize care. However, providing greater equity through this expansion could actually lead to what I'll call efficient moral hazard. For example, if providers have market power, are keeping prices below a socially optimal level, if individuals don't, as a result, consume an optimal level of care, well, having this insurance lowers their out-of-pocket prices and pushes them toward a more optimal level. If individuals are ill-informed about the appropriate use or level of care, having lower out-of-pocket prices can also push them to care. And finally, if individuals impose costs on others, and the classic example of not getting care for communicable diseases, well, having insurance can actually improve efficiency by inducing individuals to get that care. So thank you.
We've had a lot of interesting things to think about, and I hope you guys are coming up with questions. We're going to have a good question and answer period, probably in about 20 minutes to 30 minutes. And we encourage audience participation, and we also encourage our panelists to hopefully disagree with each other and get a lively conversation going. So the main question that I've always been interested in, and that, it's amazing now, certain people, particularly those who are subject to the individual mandate and don't have employer sponsored care or sponsored coverage, everyone I speak to, especially doctors or the self-employed, have an opinion on the Affordable Care Act. And sometimes they're so excited, and also the people I've written articles on, I can't afford, I'm just going to pay the penalty, I can't afford it. And other people have said, thank God for Obamacare, I've never been able to get coverage, I have diseases that I have to get addressed, but I can't afford it, so thank God now I can finally have insurance and get my issues taken care of. So I wanted to open it up to the panel and see, is the Affordable Care Act affordable coverage?
So,
What do you mean by affordable?
That's the question.
So first, even before that, I think you have to say to whom, because people are affected in different ways. People who were sick and self-employed and not in employer-provided, large employer-provided care, it's much more affordable to them. It's much more affordable to enormous numbers of people getting subsidies. There are people who are losing out, and there are people who haven't thought about why it's valuable. So people are losing out. If I was a healthy, self-employed person in the kind of insurance pool that was only available to healthy people, I probably get great insurance at great prices, and I lost it because I'm being forced to pool with sicker people and pay for them. And in some sense, the employer-provided people aren't being forced to pool with them. There are taxes, but so those people are losing. I think some of the people who have sticker shock, haven't thought about what it means if you really get sick or what it'll be like when they're older. And some people just don't know about the level of subsidy. But many people are not aware and haven't thought about the fact that, this stuff saves your lives. Healthcare does amazing things, and it's not an unreasonable thing to spend a tenth of your income to do that, but people think it is.
Right, and I mean, it is the way the subsidies are structured, it's a sliding scale, so if you make 300, 400% of the poverty line, you're paying about 9.5% of your income. So from a family earning $40,000, they're paying, someone under $4,000 a year, which for a family struggling on $40,000 to pay the rent, fill up their car with, with gas, pay property taxes, everything, all the costs are rising, another, $38,000, God forbid if they get in a car accident, they'll be very thankful, but, it is a burden to some people.
I just want to point out a couple of other things, which is that people are really unaware of what insurance costs, and they have been for a long time. So that, for example, if you got your insurance through your employer, you find out in your paycheck every 2 weeks what your contribution to that cost has been. And people tell me all the time, well, I really am aware of how healthcare costs are going up because I'm aware of how my premium contribution is going up. They have no clue that their employer may be paying 3 or 4 times what they are paying. And until just this last year, when employers were required on once-a-year basis to actually tell their employees what their contribution was to their health insurance, employers never did it. And so there's a lot of people out there who were not aware of how costly health insurance has always been, even for the healthy.
Let me ask, for those of you in the audience who've had employer-sponsored care, what percentage do you think you pay as a person as opposed to the company? Less than a third, I think, right?
Average is 25%. On the average across the country, it's been 25%. It's probably going to go up, but on the average, it's been 25%. So, yeah, it is it's expensive, and I think we don't realize how much we are already spending. The other thing is that nobody's mentioned yet is that we specified a benefit package, and we specified a very complete benefit package. And I think there are a lot of...
What do you mean?
With the ACA.
ACA.
There is a benefits package, and it's not skimpy. And that's, I think, an interesting issue that I would love to hear economists talk about and validate.
But I think there is at least one plan that's available, I think, to low-income individuals that is less onerous.
Less rich.
Less rich, I believe.
The catastrophic?
Yeah, there is the catastrophic, and then, well, there are two plans. There's sort of a younger
Which is the
young
catastrophic?
plan. And then I think there is a plan for individuals with low income, I believe.
You can get a hardship exemption
Right.
if you're 30 or over. You can get a hardship exemption to buy the catastrophic, but it still has the 10 essential health benefits.
Yeah.
It's just that it doesn't have the. You're just not eligible for subsidy.
And I've heard someone say that if you can't afford insurance, you really need insurance.
I want to just also comment, I'm sorry.
Yeah, and I think also, another way to sort of look at this affordability issue is sort of what's the net benefits from obtaining insurance. And that is, okay, sure, you pay this premium with certainty, but if you get sick, you get a fair amount of protection in terms of what you would expect to get reimbursed for. And so even though just, when you look at the premium, it may appear to be onerous, when you look at the net benefit, there may be a real payoff to doing it.
But regular people have
Right.
difficulty with that.
I think the issue that I was very troubled by is that for most people, the deductibles are very high.
Very high.
And much higher than were typical in the overall insurance market. I think in many ways that's where the sticker shock has been for people, is to recognize that they're paying this premium and they're not going to get covered until they spend $3,000, $4,000.
For the silver plan, which the benefit, which the subsidies are based on in many states, it's about $2,000 deductibles. So I have a friend who's paying $200 a month and is not going to get care. She'll get 3 visits a year, and then if anything else happens, she has to spend $2,000 out of pocket before she gets anything else. So for her, she's 28 years old and doesn't have a problem, doesn't have any medical issues. For her, it's feeling pretty onerous.
I did just want to respond to something that Shoshana said about the richness of the benefit package. There is a direct effect, it's true, of the richness of the benefit package on the premium, but a lot of the people who feel like they had a great plan and it went up and they had the skimpier plans, they were benefiting from positive selection. The skimpy plans were attracting the lower risks, and a lot of their sticker shock, it's not just, oh, you're getting these added benefits, it's the selection. Yeah. So, and I think that is also something that that is not widely appreciated in the complaints that you hear about, why do I have to have this richer thing, I'd rather have a catastrophic plan.
Okay. One thing I'm interested in, Shoshana, you brought up in your lectures, you're saying that the administration and its allies did not do enough to to reach out to the low income and the uninsured. I had actually listened to many of the board meetings of Covered California with its executive director, Peter Lee, and some of the criticisms, and the state did do very well, and it was one of the leading states in terms of sign-ups and outreach, but even there were many Latino community groups who during the course of January and February were very concerned that there was not enough outreach, and I think overall California is not that pleased with how its outreach to the Latino and many low-income neighborhoods.
Nobody should be satisfied with how we've done with the Latino population.
So what would you say, what would be some of your solutions?
Well, I think it's really a matter of resources and expertise. I mean, I lived in California for 20 years, and there is expertise in that state about communicating to the Latino population. And Peter Lee, I should admit, is an old and good friend of mine, somebody I have huge respect for. But I think they did not do a good enough job. They may not have hired the right communications consulting firms. And I mean, sometimes when you get down to it, it's that level of decision that really can have an impact. I mean, I watched California roll out a tobacco control, campaign, media campaign that was very carefully targeted to different population groups, and the stuff that they did for the Latino community in that environment was spectacular. So for me, it's not just that they didn't do a good job but that they didn't do a good job, as good a job as we know how to do. They didn't, to put it another way, they were not sufficiently evidence-based in what they did, you know, because there's a lot of good evidence around communication issues as well as insurance issues.
I think another issue is that at the state level, there may be a perception that there is a hostile environment in terms of immigrants enrolling in social insurance or social welfare programs, and that could deter them from taking the initiative to enroll.
On the state level?
Well, the exchanges, for example.
It would deter the states from reaching out to outreach for the immigrants, or it would be deter
the immigrants from reaching out to the state because of this sort of wave of sort of hostile legislation.
And they're used to flying under the radar
Yeah.
in many cases. Okay, I mean, I had spoken to several Latino outreach groups, really people, navigators who were on the ground trying to reach out, who had gotten some money. There were millions and millions of dollars that flowed to different community groups on the ground to try to reach out to these communities, and they said it was very difficult in multiple levels. Some of it was because there was an undocumented member of the family, and they were afraid it would bring the authorities. But in many cases, they said that the people they were trying to reach out to just had no experience with insurance and just didn't understand it. And they said it would take 7 or 8 attempts to get them to sign up before they would actually come in and sign up.
I mean, I think this issue of understanding that insurance actually does require you to pay something out of pocket is really a big deal. Because I think this is not the first time that we've heard evidence of people resisting enrolling in coverage because of the perception that everything should be free.
What's interesting, however, is that when the state children's health insurance program was rolled out, there was an enormous emphasis on getting people enrolled. And this was a big change because the Medicaid program in the past had been, trying to leave the door open, a sliver for people to be able to get in order to be able to save the state's money. But under the S-CHIP program, basically the feds were carrying the freight for them. We learned an enormous amount about how to reach out to Latinos, about how to reach out to immigrants, because the S-CHIP programs were really anxious to do that until they sunsetted and they got frozen, and then all the same old techniques got taken out again of making it harder to enroll and re-enroll.
And by the way, as far as sticker shock goes for the low-income and Alan, this may be what you're thinking of, there's a separate special cost-sharing subsidy for those making 250 or 250% of poverty or less, which is about $28,000 for a family of 4. So they have lower deductibles and co-pays and such. But I mean, for many of the people earning more than that, if you're earning $29,000 or $30,000 for a family of 4, you might be paying $60 to $80 to see a specialist. So for many people, and that's after you've hit your deductible. So for many people, that seems pretty pricey.
What should we do in response to that? Because the issue is if people are not insured, I mean, we're going to bear the costs. So we can either bear the costs indirectly or bear the costs directly in terms of beefing up the subsidies, for example.
So is it possible to create insurance that, many of the insurers said there's a lot of backlash. I'm sure everyone familiar with the idea of narrow networks? That many of the doctor networks, many people were complaining. This is why you've heard people say you can't keep your doctor, you have to find another doctor, because many of the insurers said in order to keep the costs down, for the insurers, these are low costs. They're trying to really contain costs, or so they say, and one of the ways to do it is to have narrow doctor networks. So is it possible to construct insurance where you don't have $2,000 deductibles and $80 co-pays for specialists?
Yeah, I mean, in the very long run, probably the biggest reason the United States spends so much more on healthcare than other countries do are the prices we pay, which go into the salaries of primarily people who work in healthcare. It's also the prices we pay for pharmaceutical drugs and devices, but it's particularly how much people earn. And you know, even adjusting for the fact that upper income people make more money in the United States, our specialist physicians make much more than people do in other countries. So ultimately, the best way to bring our spending down and make insurance more affordable is to try and reduce the earnings of specialist physicians and other people who work in healthcare too. And how do you do that? And how do you do that? You do that by sort of putting pressure on them to lower the prices. And the narrow networks have a lot of effects, but it's basically saying, we're only going to send you to doctors and hospitals who with lower prices. And that's how they get the bargaining power. I mean, there are other ways to get the bargaining power by the government acting like a monopsonist and saying, you know, we're the big insurer in town, as they do with Medicare. This is what we're paying. You don't like it? Okay, get lost. But people are afraid to say get lost. So I think that the narrow networks in that sense are a transition. Having said that, and this is something I've had personal experience with, you know, when you choose a plan, you don't know what you're going to have. And then you get sick and you discover that, hey, there don't seem to be any experienced neurosurgeons in what I have in my network. And that's not something people can sort of see in advance. So, you know, it's not always pretty how it ends up working.
Right. I mean, there was in New York City, for instance, many of the major hospitals and Sloan Kettering are not in a lot of the plans. They're not in network. And in New York State, there are no out-of-network benefits. And in Westchester Medical Center, which is the primary hospital in Westchester, was not in many. I think it was only in 1 or 2 of the plans offered in Westchester. And when it hit the papers, all of a sudden there were some compromises, because a lot of the times the doctors don't want to accept the reimbursement, or the hospitals don't want to accept the reimbursement that the insurers are offering, so they opt not to be in the plans. But then you've got the backlash.
I mean, sometimes you don't have a choice. For example, in the community I live, the hospital that we've used only has one anesthesiology practice, and that practice is out of network. So you basically don't have a choice.
I also wonder whether or not this is going to be a short-term or a long-term problem, and I really mean wonder about it. I'm going back to a period of time in California where for the first time there was what was called a czar in the Medicaid program, which is called Medi-Cal in California, and they introduced per diem hospital rates. So the hospitals were negotiating with this czar, who happened to be recently retired Blue Cross executive, right? And he reported to nobody, he had literally no accountability, and he was negotiating these rates. And of course people were screaming and yelling, but within a year, 2 years, 3 years, those things kind of got, you know, they kind of got balanced out. And I think we're going to, you know, we're going to have to see if that happens. The thing that I find fearful is that one of the kinds of scare tactics that people use are, not only are these doctors not going to be in the network, they're going to refuse to accept insurance from anybody. This is happening.
It's happening in New York.
It's happening in New York, particularly. One of my husband's physicians accepts no insurance, and we pay entirely out of pocket for that, and that is full charges. That is not any kind of discounted rate, you know. So, you know, what I think we all fear is having a very tiered system where there's a very small percentage of the population that can afford, basically, very small portion that can afford virtually to pay for their own care.
Right, and it exacerbates the inequality that the Affordable Care Act is looking to address.
Yeah, so since we're talking about high prices on the one hand, I mean, there's also an issue of low prices. We have this Medicaid expansion, and physicians who are reimbursed by Medicaid typically get very, very low reimbursement, and so therefore is the supply going to be adequate to meet this increased demand, which I think is another issue.
Certainly an issue. We had a question from the audience, so
Yeah,
do you want to? Is there to be a mic, Mary, for the audience? Or?
I can talk to can talk really loud.
David can talk loud.
I'm a professor.
Just introduce yourself.
So I'm David Yeager. I'm one of the three central faculty graduates in the economics program. So a lot of what you've been saying in the last 5-10 minutes sounds to me like the optimal thing to do would be single payer, in terms of at least keeping costs down, and perhaps providing more access. I hear a lot of arguments against single payer, and I realize there are political difficulties with that. But political difficulties aside, is there an economic reason why we would prefer not to have single payer?
So in terms of negotiating power with prices, single payer has enormous advantages, no question. Arguments about, I think in many respects, the biggest argument against single payer is that given where we are today, the amount of disruption you have in the economy by trying to jump there is enormous. But the idea of moving there incrementally, I think the biggest reason is, quite frankly, I was going to respond to Shoshana, that I think in the United States we want a multi-tiered system. We tolerate more inequality than people do in many other areas, and I think that it is probably inevitable that we will have people who buy out, and in European systems like Britain, you see increasingly the top does buy out. Does that mean we shouldn't just have a single payer and also default non-means tested entitlement insurance as a default? And if rich people want to buy their stuff, great, wonderful, fine, let's do it. But getting there, how you get from our incredibly, I usually like to call our healthcare system a fractal because it's so complicated, and when you magnify it, it's equally complicated, it goes on forever. But yeah, there are a lot of advantages to single payer.
I mean, is there a good economic argument against single payer? I mean, like I said, I understand the political difficulties, and it may take a long time to get there.
Let me take a crack. And let me take a crack at that. And then, well, choice. I don't think that's an economic argument necessarily, okay? But it certainly is a political argument. What I originally am a person who I shock all my left-leaning friends by saying I'm not in favor of single payer because they expect me to be, because I'm so big on universal coverage. What has always concerned me is a fear that in this country we are overbedded and over-resourced, and in a single-payer system, you're going to utilize all the resources you have to the maximum availability of those resources. In a place like Canada, they not only control prices, but they also control things like how many MRI machines there are and how many hospital beds there are. And I'm not sure that we're willing to do both of those things, and I think that's one of the aspects of the system that would be very difficult to transition away from. But I want to hear from Alan.
Well, I think choice is an issue. I think on the plus side, I mean, the argument has always been that the administrative costs would be much lower, and the current administrative costs represent a significant amount of what folks call waste in the system. And so you would, you gain somewhat more efficiency and recover those so-called waste dollars with a single-payer system. But I think that it would ultimately gravitate to a tiered system, because I think people would sort of opt out and seek other types of care, those who have the ability to pay, for example.
But would that be multi-tier, or would that be really kind of like almost like a 90-10 system or an 95-5 system? So it's really only 2 tiers, where there's the people who get the single-payer coverage and that very small percentage of people who can really go it alone.
I don't know that it would be smaller. I mean, it's different in Britain because the national health insurance was not just the insurer, they were the provider, although they're decentralizing to some extent. But, employer provided additional insurance, which isn't an alternative in Britain, it's a top-up. So with people with supplementary additional insurance in Britain, they have a heart attack, they still go to the national health insurance, and in that sense it's different from some of the other countries where people get, other European countries where people will get alternative insurance. I mean, I think you could see multiple levels, but I think we're fine with a certain amount of inequality in this country. I don't have a problem with it, and I think that, you know, having a base level, but I think Shoshana's point is correct, that if you put a sort of single payer with a reasonably high price, if you took single payer and you really had the political will to clamp down on the price, I don't think you'd get the excessive usage. I don't think it'd go crazy, but a lot of it is in the price. The price not only has a direct effect from the high prices, but the incentive to do more care is so high. You lower the prices enough.
Can you introduce yourself?
I'm an insurance broker in business the last 35 years. And you're talking about the sticker shock, and I think the current pricing for the ACA is not really taking into account things like pre-existing conditions are eliminated, and the children covered till age 26, in New York until age 29, you have pediatric care, you have unlimited psychotherapy care now, you know, have unlimited chiropractors. All these things will be used, and wait until next year when you see real sticker shock. A couple of weeks ago, I went to a convention of all the health carriers in the New York market, and a couple of the carriers were very, very underpriced. They were actually about 25 to 30% less than the new carriers. They were 30% less than the incumbent rates. And I posed the question, why are you so low? Why are rates so low? And they said, well, next year, if we're in business, we will probably raise our rates. So I think we're not really focused on all the new mandates that really cause sticker shock. I mean, right now, we haven't seen anything yet. And another thought is that the ACA, as far as I know, really did not address abuse, did not address fraud on medical care, they're addressing waste. I know there's certain special record keeping, which seems to negate the need for multiple testing in certain cases. And I know there's somewhere buried in the Affordable Care Act certain penalties for people who smoke, but I think there should be more regard for ways to keep pricing down.
Do you really think that waste, how much of a percentage of our healthcare costs do you think is waste?
Like fraud level waste, not
abuse, waste. And
they're all different though. Fraud and abuse.
We'll take it together. You're looking at probably
waste in general is about 30% of
Right. That's the use of unnecessary care. We define that as waste.
but that's a very different.
10% fraud, that way fraud.
There is somebody that's actually, there is a part, one of the parts of the ACA that specifically addressed it. There is a person who is an old friend of mine, he's a doctor, lawyer, what could do one better, who is in charge of it. There's, you know, there is stuff there, but I have looked at a lot of literature on what the drivers of healthcare costs are, and that doesn't, it's like that's medical malpractice. You know, it's often discussed, but the actual impact, I think, frankly, the Dahlia is right, that this is about prices. It's also about unnecessary utilization, but it's really about prices.
I mean, the studies comparing the U.S. and Canada, there are three big things: prices, administrative costs, and technology. Okay, we have higher tech care. The thing is, you know, one person's waste is another person's valuable care. I mean, some stuff is clear waste.
Another person's income.
And again, I mean,
When I say waste, I'm talking about multiple electrocardiograms, multiple blood tests. You go to Dr. A, does a test on you.
there's coordination problems. We do have, you know, we have such a fragmented system. We do have coordination problem type waste as well, and that contributes to it. But in magnitude, I agree. I want to go back to what you said about the sticker shock, because I know the first first bids, as it were, from the insurers have come out for this is what we propose for next year. And my understanding is it's not like there's some clear enormous jump. Some insurers are way underpriced, some overpriced. There are so many things that are so different. They're getting, you know, the ones on the exchanges, they're getting different pools of people. They didn't know what mixture of healthy people they were guessing. They still have very little data and they're guessing again.
CBO has estimated that the expected increase in premiums is below what I guess the alarmists have thought they would be.
Well, the first premiums have started, there isn't really a lot of information, but Virginia's released some of the early premiums, and it's really very much a local market. You know, people have said, oh, there's 8 million people who've signed up on the exchange, and I think 25% of them are young. That doesn't actually mean anything to the average person, and not in the sense that they don't understand it, but it doesn't mean anything to their wallets because it's really going to be a local market. So in Virginia, they've announced that in some markets in Virginia, the increase is going to be some point percentage, 0.2%, 0.5%. And in other parts of Virginia, again, where the balance wasn't as, was different than what the insurers had expected, it's going to be in the low double digits. So we also have in Washington State, some of the numbers have started to come out. And there's a new insurer, Molina Healthcare, which was mainly a Medicaid managed care plan that's now entered the market, and they're going to be reducing their costs. So, but we have time. It's going to take some time before we really get.
I mean, there are two things that could reflect. It could reflect, for example, differences in the age distribution in these pools. It also could reflect differences in practice patterns. And trying to sort of tease out what's driving it, I think you should sort of focus on those two issues.
I think, though, that we have a lot of experience around these same issues by looking at the history of Medicare managed care and also the introduction of the Medicare Part D benefit. Both of those were cases which, like the ACA, are engaged in an entirely private insurance market to compete, in a sense, for a population and their care. In the case of the Medicare Advantage program, as it's called, there was a public plan, which of course we didn't include in the ACA, but in my experience, there's a whole long history since 1985. It's nearly 30 years now. And yes, the Medicare Advantage plans lowballed at the outset in order to attract people. Who they ended up attracting because of how they're structured things was a lot of low-income people. And it was a boon for them because the out-of-pocket costs under those plans absolutely plummeted for people. But then the plans, something really bizarre happened that they forgot that was going to happen, and that is that people got older. I mean, you'd think they have figured that out, but they didn't realize that they were not going to be ever having the same risk pool in year 5 as they had in year 1. And they never took that into consideration. And so those prices went up. A lot of plans exited the marketplace. And that's when we started paying them more.
Well, I think they also undercut to gain market share.
Absolutely.
And so they then adjusted, as you said,
over time. And they had an ability to do something which is not available to them in this setting. And that is Hal Luft, the economist who was then at the University of California, San Francisco, now he's at the Palo Alto Medical Foundation. Hal talked about the fact that the way that selection worked in a lot of health plans was that they would selectively discourage people from remaining in their plan if they were very sick by making it very hard for them to get the services they need. I don't think that's going to be as easy for these plans to do. Somebody's going to have to take that person, right?
There's also risk adjustment is far from perfect, but it's a lot better
than zero.
Yeah, it's a lot better than zero. And I think the other thing I'd like to bring up is this issue of the healthcare cost in general escalation that has really the slowdown that started in around 2006, 2007. I mean, healthcare expenditure growth that exceeded GDP growth by, 6, 7 percentage points, you know, for decades. Now, we got used to that. We thought it was like a law of physics kind of thing. You know, technology improvement, you know, healthcare expenditure growth way in excess of GDP growth. It would be more than 100% of the economy. And it's sort of the technology rained down from heaven, and there was nothing we could do about that. Well, you know, there have been slowdowns before that didn't last. There was one, you know, when managed care got going and people thought, we've conquered this, and it came back. So one doesn't want to be too optimistic, but there was a persistent slowdown in healthcare expenditure growth that preceded the recession, and that analysis shows much of some of the slowdown was due to the recession, but a lot of it was not, and people, you know, are still arguing about what it is and where it came from, but that is enormously powerful. I mean,
So what were some of the reasons if it wasn't the recession, it wasn't ACA?
So what the studies show is that there's been a slowdown in technology diffusion. So pharmaceutical drugs and other new technologies, which formerly there were lots of new and they spread really quickly, it slowed down. And sort of why the extent to which, you know, some of that may be high deductible plans, people paying more out of pocket with more cost sharing, and yet the size of the effect was more than you'd expect for the amount of cost sharing and increased cost sharing. Some of it may be other incentives towards providers that don't understand. I mean, one thing to be said is that these slowdowns are in Medicare. So a lot of the slowdown is in Medicare, you know, I think people are still struggling. Some of it are, you know, higher prices that people had to pay out of pocket. Some of it is lower prices that providers are receiving. So it certainly can't be responsible for all of it, but there's this really obscure thing called the part of the Affordable Care Act, the Medicare Productivity Update. Previously, hospitals, doctors were supposed to get an increase in what they received that was based on their costs, and the idea was there was no increased productivity in medical care, even though in the rest of the society we have increased productivity all over the place. And they decided, no, we think medical care is going to have productivity, and so we're going to clamp it down. I think it's by 0.25 percentage points. Do you remember?
But Alan maybe disagreed with you.
2011.
I guess I wanted to make 2 points. One point is the fact that patent terms are expiring on drugs, and so there's, you know, more major right, and so there's the increased use of generics. But Victor Fuchs has, I think, argued very strenuously that the growth in costs is pro-cyclical. And so consequently, when the economy starts to regain steam, we're going to see expenditures or the rate of increase rise.
And there have been some hints about that already.
I mean, I think there's no question that has happened and will happen, but there have been multiple analyses and looking at the slowdown in Medicare recipients, and the Medicare slowdown wasn't, if you look at who cut back, the CBO study.
I understand that it did proceed, and I think the two extreme estimates are the Kaiser Family Foundation said, I think that's 77%, and then I think David Cutler's done some analysis, and his estimate is about 37%. So it's still a very sizable impact.
Okay. Let me just ask, I think, Jay, did you have a question earlier?
I was just going to ask about the, not the tiering effect, but the 19 states that have not voted.
It's more than that. There's some that are on the fence, but it's more than 19.
The state exchanges versus the
state. No, the Medicaid expansion.
Medicaid expansions.
I was going to look at the economic effect of that. Do you have workers moving? Do you have state legislative pressure?
You could have
hospital lobbyist pressure.
As the hospital lobby's pressure is what I think is actually going to gradually shift that over time. I mean, we've already seen some states fold in the sense that they, I mean, New Jersey, Was Chris Christie gonna, was Chris Christie gonna Medicaid, expand Medicaid if he could if he could avoid it? No, he wasn't. But his state legislature, of course, is able to tell him that yes, he is going to expand Medicaid. But so is his hospital lobby.
Right, and I think the opposite is actually happening in some other states where the governors have wanted to expand.
Yeah, there are at least 5 states,
have,
Florida in particular.
But there's a real sort of equity issue, because if you're in a state that doesn't expand, and you are someone whose income exceeds the state's thresholds but falls below 100% of poverty, you're out in the cold, basically. You cannot get a subsidy, nor are you eligible for Medicaid. And that's a real gap and a real equity issue.
But with the, they don't have much of a voice, so who's going to speak for them? Some of the hospitals have been coming out now with their earnings reports, and they're showing a real schism, a real divide in what's happening in terms of Medicaid admissions versus uninsured admissions, and you're seeing that
there's another issue, the dish payments
are going
down, and so
Let's
hospitals,
explain that to people,
right,
they
so
may not know our acronyms.
I think under Medicare, hospitals that take a disproportionate amount of Medicaid, take a disproportionate amount of uninsured admits, get compensated for that, get extra money. And because of the existence of the exchanges and the fact that it's assumed that people will now go in the exchanges and consequently the uninsured problem will be less, I guess the administration is cutting back on these disproportionate payments.
That was in the law.
it wasn't going to be needed because there wasn't going to be anyone who was uninsured.
That's right.
That was one of the savings that enabled it to come out looking cost neutral.
Right. But if you look at Texas, I mean, this is a state that I did. There's a lot of uninsured people in Texas. It has the highest uninsurance. I think it's almost 1 1/4 people in Texas are uninsured. They're getting sick. They're getting into accidents. They're going to the hospital. Governor Perry says that the state can't afford to pay for it, but who's paying for it? I mean, there's somebody who's paying for it. And in Texas, they have, in many places, they have hospital districts, which tax the residents on the county or district level. So sure, it's not the state that's paying for the Medicaid. And Medicaid expansion, of course, is 100% paid by the feds for the first 3 years, and then it gradually steps down to 90% over a couple of years more. But the states that have not expanded Medicaid, their argument has been that they can't afford eventually that 10%, and they're concerned that the feds may change the formula in the future. But again, their residents are paying. Somebody is paying for the health care of the uninsured.
Alan, you mentioned that there are differences in canons of practice. And I think evidence is starting to emerge that there's also sometimes high variance in prices for the same service. So to what extent do we think that there is an opportunity and an incentive for this variation to result in better quality and lower price?
That's a big question. Well, I think, I guess one initiative of the ACA is the notion of trying to instill the use of evidence-based medicine. And so if you're trying to get people to respond to evidence-based, then perhaps you can, eliminate some of the variation in practice patterns and then provide more uniform quality. So that's sort of
is there
one.
any incentive for that to happen, or is it just that the information itself becomes available by the time?
But we don't really have the information. We don't have the price.
There is a huge movement right now for increasing price transparency.
Right. We don't know it yet, so there's no.
But here's the problem: the data are lousy. The data are irrelevant to consumers because they're data about charges, which are meaningless. They're not data about what it costs them out of pocket, or even what their insurance company is going to pay for it. This is something I've studied. And the other big problem we have is the mental model of Americans, which is not surprising that they believe that higher prices are a signal of higher quality. And And they also believe that the more care you get, the better off you are. So we've got purchasers, private and public, pushing this idea of price transparency, even though they may actually be creating incredible, weird incentives if they do it. And it's very peculiar. The only thing that I can say is that the value-based purchasing initiatives that are built into the ACA are a small attempt to try to get some of this under control. And maybe things like penalizing hospitals for readmissions is a way to save money and improve quality at the same time. But we don't really know whether or not that's going to work.
I suppose you could also shift cost sharing so that for a given procedure, if the price is above a particular level, well then your cost sharing gets adjusted accordingly so you bear more of that cost.
Well, that's already being done by purchasers. They're having what they call reference pricing, so they will reimburse X, and if you were to charge a cost more, then you have to pay the 100% of the difference. They are also...
But many people don't know that. That's the reasonable and customary concern, and most people, when they get their bill, they think that their insurer accepts their doctor, their provider accepts their insurance, and all of a sudden they're getting socked. I think it happens a lot with dentists. Also, they get socked with extra costs.
I'm sorry to say that in front of you, but they're not doing a very good job, nor are the employers, of explaining these new things. Like, they also have tiering, right? So they'll waive copays. In the state of Maine, the state employees health plan picked some hospitals that had a profile of high quality and low cost, and they waived deductibles for their state health plan. And that, one of the biggest hospitals in the state got hit by that, and they really saw a market share shift, which you rarely do because of an insurance design, but they saw it. And that hospital noticed, and they got their act together and they reduced their costs. So,
I just want to say one thing about the variation in prices. So I think the variation in treatment and the variation in prices are really two very different types of things. Some of the variation in prices has gotten a bad rep, I think, because some of it is just completely arbitrary differences in where they load the joint costs. So much of healthcare is joint costs, and essentially what happened is somebody made, decades ago, this arbitrary decision to put more of the joint costs on aspirins in some hospitals, and less of it on X-rays. Another one made vice versa, and ever since then they've just been upping their charges everywhere by the same percentage, and you get these wild-looking things, but they're really just saying, we got to cover the joint costs somehow, and this is how we're doing it. And I think that's a different issue than, systematically some hospitals and doctors being more expensive than others. And I think these two things are being conflated now.
Elizabeth Rosenthal, who writes for The Times, has done an absolutely terrific article tracing the growth in costs of a saline solution that's used to hydrate individuals, and showing how the distribution channels that this saline bag travels through adds enormously to the cost. I mean, it's a really incredibly article.
Get some questions over there. You want to just, gentlemen first, you want to say who you are?
My name is Gabriel Mosticiano. I'm a candidate here at the Garrett Graduate Center of Economics Department. I had a question about, kind of related to the state's issue that John ran before. So this week we saw Indiana say announced that they're going to file for a waiver so they can eventually expand as well. So I'm curious, in a lot of these states that have not done the Medicaid expansion, politics aside, they're not going to have their legislature or governors change in the foreseeable, at least in maybe a year or two. Who's lobbying, or what's the policymaker's role at the state level there that got Indiana to change their mind, for example? Or what might happen in other states? You mentioned hospital lobbying before, so is that going to be the primary concern?
So far, that's been a major one, but I am not following that from a political, stakeholder kind of perspective. Do you know?
Well, I'm not sure that I have a handle on the politics, but a lot of these waivers are requesting that Medicaid, that the expansion enrollees be enrolled in private plans,
Merging with the plan they
right,
already
and
have.
so that clearly is income to private plans, and consequently perhaps is an impetus to move the expansion in those states.
I have a question regarding the healthcare costs. So other than patent cliff, the prescription drug patent cliff, we've seen that how hospital and nursing home costs have gone down since early 2000, before the crisis. And so if cyclical is a factor, we are out of recession for 4 years. Why hasn't healthcare expenditure gone up? And since the healthcare expenditure hasn't gone up, why do you think in the next few years it will go up? And do you think Affordable Healthcare Act will drive up prices since it drives up by driving up demand?
Do you want to talk about the recent
Well, no,
spike?
there's I think the last quarter was a 5.6 percentage point spike, or percent growth in expenditures, which was well in excess of the percent increases in the prior few years. And that's raised all sorts of alarms, and people are, trying to discern whether this is a one-time spike and whether it will continue or whether it will go back down to the prior rates of growth.
Well, my understanding is that part of that spike, so some of the spike is recovery from the recession, which is lagging and does tend to lag, and some of it is newly insured people on the Affordable Care Act, and some of the newly insured stuff is temporary because they weren't insured and they have sort of a backlog, and some of it's likely to be permanent. But my understanding, I think Peter Ortzag, among other people, has done this analysis, that some of it's actually not real, that the spike is because they're projecting the healthcare expenditures, and among the things they use for projecting are the number of people who are insured, but the facts are that some of the people who are insured would have gotten care anyway, and the estimates don't do that. So I think people don't know how much of the spike is there, but basically we don't know if the slowdown, to the extent it was due to slower diffusion of technology, we don't know if that'll continue or not. And to the extent that it was due to people having a higher out-of-pocket payments, and the extent it was due to paying providers less, are we going to keep doing those things or not? So those are all open questions. But I do think the agreement is that we are starting to see some effect of the end of the recession and that it lags.
I mean, I think we're gonna have to wait a while. I mean, we have this. We're gonna have, a large number of newly insured individuals. There's going to be an increase in demand, and consequently, we're going to see whether that is a temporary increase or whether that is a permanent increase. So I think it's too early to discern whether this spike is a short-run, pickup or a longer-term kind of phenomenon.
I guess I would, Sherry Bleed has emphasized the fact that because we pay so much higher prices in the United States, if we could figure out a way to get those down, we could have a substantial period of lower growth. So, I mean, she referred to it as the tar sand of all the oil. If we can figure out how to get the oil out, we could have a long period of much slower growth. And I think, do we have the political will and the mechanisms to do that?
Well, I think the other issue here is that there are also a lot of variations within healthcare over what's expensive and what isn't expensive. And I think that many solutions to reducing prices are not subtle solutions, so that they may reduce prices where they're already perhaps too low, as I might say in certain primary care specialties, which would really be a disaster, because that could then, throw people into the willing arms of the specialists. And, there are a lot of specialists who are more than willing to try to pretend to be primary care providers for their patients. And, it happens all the time. You have a heart attack and then your cardiologist becomes your primary care doctor. They don't know how to do primary care. And, you know, so there are these, this is an issue where the quality then begins to be very questionable.
One thing to also note is we're talking a lot, of course, about the newly insured in the exchanges and in Medicaid, but you also have newly insured in the employer plans, because you had a lot of people, you know, especially in smaller plans, in smaller companies, that didn't take their employer coverage because they didn't have to, and they felt they were healthy, and maybe it was expensive. But Walmart came out today and said that in their first quarter, their healthcare costs, because of increased enrollment, has gone up $100 million for the quarter. So it's increased enrollment and increased utilization, but they have 1.1 million people and associates and families who are added to the rolls. Why? Because now there's even though the employer doesn't have to provide yet until next year, the individual mandate exists, so these associates and their families didn't want to have to pay the penalty. So I think, Merih, it's 7:30. How much longer should we, do we have, how many more questions do we have in the audience? 2 more? Okay. 3, 2? Jesse?
Yeah, my name is Jesse Margolis. I'm a student in the graduate program in economics. And it seems like one potential benefit or effect, economic effect of the ACA might be to some degree to decouple insurance, health insurance for individuals and families from a particular employer. And that would have interesting economic impact, possibly on entrepreneurship or job transfer. But I don't know the act well enough. To what degree does it really do that, or may it in the future, or is that a very marginal part of the act?
I think this is what Alan talked about. It's a big deal. This is everybody doesn't have coverage. Lots of people who, you know, and there's a way to get coverage outside of your employer's coverage. That's the basic thing. You don't have to stay with your employer anymore in order to get access to coverage.
That's true.
But you do to get access to your employer's premium contribution.
And I think there's sort of two minds to this. There have been some, I guess, recent estimates that suggest that employers are not going to drop coverage as such. And then there's a very recent Urban Institute study that suggests that if in fact they were to drop coverage, or I could say if the employer mandate was eliminated, it would not have a real impact on the number of individuals who are getting coverage from their employees. And the notion is that employers use this as a value benefit. Employers use it as a mechanism of competing for labor, and so most of the analysis suggests that the system is going to continue.
But on the flip side, Ezekiel Emanuel says that by 2025, fewer than 20% of workers will get health care.
I think for low wage, for firms with low wage employees, I think that those firms that are sort of that have a substantial number of low wage employees, those employees may actually be better off going to the exchanges. They'll get subsidies. If those subsidies exceed, for example, the tax subsidy they get from employer-sponsored insurance, then those employers may be willing to sort of drop that coverage. The other issue is that those employers can't necessarily shift the cost of insurance back to the employees. But if we believe that employees pay for their fringe benefits, then given low wage, given workers that are near the minimum wage, it's not possible to shift the cost back.
I think Jesse was also talking about just the job lock of people staying in jobs because they're afraid of losing the benefits and being cast off into, the individual insurance market, which was risk rated, so you're at risk with your health status. And I think that is a big deal. I agree with Alan about the employer provided, everything he said about the low wage, the high wage, not giving it up, and an additional reason, not just the tax benefit and so on, and having nice things to attract people, but the employer provided, they have to pool with the exchanges, which have poorer people and to some extent sicker people, and so for the same price, they're not only getting a tax subsidy, which is better for hiring young people, but they're also able not to pool with, and not as, so they get the advantage and have a sticker and or people have to pull this up. I don't agree with, I think none of us agree with Ezekiel Manuel for the upper income, but for the lower income people, I expect to see it. I expect to see employer provided go away, and quite frankly, you know, it's a good thing. Why should some restaurant franchise person have to be an expert and worry about health insurance? It's something that is.
But also the other issue is that there was a chunk of ACA that was postponed, which were these shops. And
2015, I think.
Yeah, so but those are for small employers.
But they're only for the real, well, the subsidies are only for the real small ones.
Yes, so that, we also don't know what that would have done.
I know, I'm sorry, I know we have a few more questions, but we've actually come to the close of our panel. So I wanted to thank you. I wanted to give the opportunity if the panelists had any closing remarks that they wanted to give. I think it was a lively, spirited debate.
I have 2 points that I disagree with.
Yeah,
so the first point is, if you're going to argue that the individual market, is pulling the healthy and the unhealthy, well, you'd have to argue that the employment-based market is doing the same, because it is within firms' community, in effect. I mean, if you read it.
Yeah, but employed people and people with good jobs are relatively healthy, right?
But older workers certainly spend more. Female workers spend more.
They're certainly pooling within that, but
and then I also, if I can get maybe the next to last word, and I sort of wanted to take issue with your asymmetric information analysis. Because I think the issue is if you're arguing that an individual does not know when in fact they're going to get sick, well, an employer, the insurer faces exactly that same problem, and will try to favorably select based on some underwriting and other kinds of screens. So I think
absolutely.
So I don't think the two are distinct issues.
So my point about the asymmetric information is not that massive amounts of selection and dumping and cream skimming go on. They absolutely do, as does self-selection. My point is that it's not a thing that you fix by getting rid of the information problem. You don't fix what most people see as wrong with the insurance market by giving the insurer a detailed health information so that they can charge that person actuarially fair premium. If I'm a cancer survivor and my actuarially fair premium is, $23,000 a year for just a single person, I don't think we've fixed a market failure. And that's why, to me, Cochrane's point, and this week, I know we agree about the market failure of the fact that you can't get lifetime insurance to the market. So it's not that, I'm not saying people don't, the insurers don't engage in those selection patterns. They do, as do individuals in terms of self-selecting. But it's not, the market failure that really matters isn't the asymmetric information, because we can't fix it with more information.
Well, on that note, I think we've given you more information about the Affordable Care Act and maybe some useful tips before you go to your own doctors and utilize your own health care. So thank you very much for coming.